So welcome everybody. We've got 250 odd people registered for today, so we're really glad you can join us. People will be joining as we speak. I can see them logging on now. We've got a really exciting session. We've got 3 speakers with international reputations, and this webinar has really arisen from the Transplant Learning Journey workstream, and this workstream is about how we manage patients with HLA antibodies. We are very kindly supported by Hansa, so we're really grateful to them for their help and support in this. And we would encourage you to register for the TLJ, the Transplant Learning Journey meeting, which is taking place 15th to 17th of November online, and you'll hear more from this workstream at that time. The aim of this workstream is really to provide a guideline for how we manage these patients. And today, what we're doing is having 3 brief presentations. It's a big subject, so we're not going to cover everything, but brief presentations as you've got listed in front of you. And the idea is to summarize what we know and what we don't know about each of those topics. What we want from you is feedback about what you, as members of the transplant community, would like to know. What do you want to see in a guideline? What are the issues that are important? We're going to be ruthless about timing today. We've only got an hour, so we've only got a short time for each talk and a few minutes for questions afterwards. I would encourage you to use the Q&A section at the bottom of your screen to type questions. Don't leave it to the end of the talk because by that time we'll be moving on to the next one. Don't use the chat function, use the Q&A function. And if there are questions, we won't be able to answer all of your questions. We'll only have time for a couple for each speaker. So unanswered questions, we will work out answers to, and we'll post them on a website and send you a link to that. We're also going to send you a link to a survey, which we're going to carry out across Europe to get a picture about how people manage these patients. So I'd be very grateful if you could fill that in. You'll get that after the webinar. So I think that's all from me now. It gives me great pleasure to introduce Oriol Bestard from Hospital Bellvitge in Barcelona, and he's going to kick off with the definition of sensitization, characterization of it, and comparison approaches across Europe. Thank you, Oriol.
Thank you, Nizam. I think you can hear me well. Okay, it's a great pleasure to be here, and I'd like to thank the ESOT for the kind invitation to participate in this webinar. So, and as you just mentioned, we're gonna focus in a pretty controversial topic, and my talk will mainly focus on trying to see whether we have a definition of a sensitized patient and what is the impact of these patients and the chances to receive a kidney transplant allograft. So I don't have any conflict of interest regarding this talk. So just very briefly, I think everybody knows, I mean, the biology of sensitization. I think we all know that unlike naive alloimmunity, the memory immunity that leads to a sensitized patient starts when there is a second recognition of the same antigen, and where a very strong and robust donor-specific immune response is going to start according to a germinal center activation, where B cells will start releasing, particularly short-lived plasma cell at the beginning. So they will start releasing donor-specific IgG antibodies, which will remain in the bloodstream for a very long time, or they may also fluctuate over time, as you can see here in this slide. So we have here defined 2 types of approaches to monitor donor-specific alloimmunity or humoral immunity. One is the one we use in current clinical practice, which is based on the serological memory, which is trying to identify or track serum antibodies, IgG donor-specific antibodies. Another one is whether patients may have B cells or memory B cells in the bloodstream, which would be capable of producing a secondary immune response and producing antibodies. So we know that there are many factors that are implied on sensitization. I'm going to be very brief. We know there is a huge impact in terms of biological gender inequity. We know women, as you can see here in the left panel, are more frequently sensitized in the high range of sensitization because, of course, of previous pregnancies. And we also know that the cumulative amount of previous sensitization events will also impact very much in terms of producing a memory B cell response, in terms of the strength of this response after a transplantation in our setting. And so, and we have, as you all know, a plethora of assays that are capable of very sensitively track the presence of the serological memory, so antibodies, as you can see here. And they can be divided in those that we need donor cells, such as the complement-dependent cytotoxicity or the flow cytometry, and they test the cross-match, a direct donor-specific cross-match. And we know that there are the pros and cons of each of them. I'm not going to go through of them, but we know that a positive complement CDC cross-match has a very high positive predictive value in terms of the risk of hyperacute antibody-mediated rejection. And also the flow cytometry cross-match, it allows us to have a high positive predictive value for acute ABMR. It has the capacity of also not only detecting complement binding and donor-specific antibodies, but also low-level and non-complement binding antibodies. And then we have those that are based in solid phase assays, the ELISA, and the most well-known, and which is used worldwide, the single antigen BITS, which is predominantly and mainly useful for having a virtual cross-match, and is extremely useful for the highly sensitized patient. And finally, although it is still on the research field, we know in the last year that it seems that there are some new assays that may be capable of also tracking the presence of memory B cells at the cellular level, and not only at the antibody serological memory level. So all these assays are impacting very much in terms of the results. I think Professor Lejeune will talk about this, but depending on the diverse pathogenicity of these donor-specific antibodies, we will be able to have different impacts, and each assay will be capable of detecting a different biological type of antibody, whether they fix complement or not, whether they can harm the graft because of an antibody-dependent cellular cytotoxicity, the susceptibility of the endothelium of the allograft, and also whether the titer of these antibodies is high or not. So all these biology characteristics of the DSA will impact also on the type of assay that we're using in our histocompatibility labs. And also, of course, the sensitivity and specificity of these assays will also impact very much in terms of the likelihood of classifying a patient as highly sensitized, and therefore being included in a prioritization program. And the CDC PRA, for example, we can have this sort of percentage in our waiting list in around 6 to 10% of patients, and it might have a higher chance in terms of receiving a donor offer because of the number of patients waiting in the list. But however, if we use single antigen BITS assays, we know that the number of highly sensitized will significantly increase, and therefore the capacity or the chance of having a compatible donor will probably be lower because of the higher number of patients on the waiting list. And actually, this is very illustrative if you can see here, and I think this is a general example in Europe and worldwide, in the US as well. As you can see here, these are the number of patients on the waiting list in Spain until 2 years ago. And as you can see here, in red, you have the number of patients that were called or classified as highly sensitized using a CDC PRA assay. However, when we started to use the single antigen BITS assay, you can see how the number of patients that were classified as highly sensitized were at least twofold the CDC classification. So increasing significantly the amount of patients up to 15 to 20, even 20% of the patients on our waiting list. And actually, this is a little bit the summary or a landscape. You can see what, according to each prioritization threshold of defining a highly sensitized patient in every country and every region in Europe or different regions as well as in the US, you can see how what are the range or the percentages of patients that are classified as highly sensitized according to each assay or approach that each region is using. And as you can see here, it may vary significantly. And a different approach as compared to the ones that is classically being used, which is trying to detect the prohibited target antigens of the antibodies, would be the acceptable mismatch program. As you know, it's the program which is used within the Transplant, and it's completely different. It's a completely different approach, and which is not based on preventing the transplant, but conversely on trying to facilitate the access to transplantation. What they do is try to identify acceptable antigens. This is antigens to which the patient has never made antibodies in the past. And they use different approaches to define acceptable mismatch antigens, which I'm not going to go over it. But at the end, what they have is the concept is that they try to enlarge the own HLA type of the recipient, and therefore to have a higher number of compatible HLA antigens. And here, just briefly, I just wanted to show you the impact of these two approaches. And you can see, for example, in our program, I think it is we can generalize this example from Spain in other countries where use a prioritization program. As you can see here, patients with the high range, even see with a CPRA 98%, 99%, they have a pretty good chance of receiving a compatible HLA organ. As you can see here, particularly those that are incident, so at the very beginning of being included in the program. But however, you can see here that those in the very high or in the highest range, in the CPRA 100%, the likelihood of receiving or being transplanted or even receiving an offer is extremely low. And in our country here, for example, it doesn't reach the 20%. But conversely, for example, and down here, I'll show you the same example, but using the acceptable mismatch program. And I think it is very interesting to highlight the 100% CPRA, which would be the blue line, which would be the equivalent that would how the acceptable mismatch program classify this patient, and would be the same as a CPRA 100%. As you can see here, the likelihood of receiving a transplantation within this cohort is significantly higher, and up to almost 40%. So there are different ways to approach this definition of a highly sensitized patient, but in any case, we still have a number of patients that will remain, unfortunately, in the waiting list because we're not capable actually to offering them a compatible HLA graft. So this is my last slide, just as a summary. Which within the engaged group, within the ESOT, made, according to also to the STAR group in the US, a definition trying to define the different categories of risk of humoral immune memory within solid organ transplantation, and particularly in kidney. And you can see here they are based on the evidence we have according to each assay and the risk of rejection or graft loss. We would have the highest risk category in red, which are those that they do have a positive cross-match, CDC cross-match, and a DSA with solid phase assay, which would be those at very high risk of developing hyperacute ABMR, and therefore transplant. It could be impossible unless we desensitize these patients before transplantation. Now we have a second high-risk group, which are those with a CDC negative, but still with a DSA, solid phase assay, and a positive flow cytometry cross-match, which are still at high risk of acute AMR or accelerated chronic AMR. But transplant perhaps is possible and might be potentially applicable, although it requires adaptation, of course, and follow-up of maintenance immunosuppression. We would have a last risk group in terms of the assay at the serological level, which are those with the CDC negative and flow cytometry cross-match negative, but still with a DSA positive at the single assay bit assay level, which are also, and we all know that they also have higher risk of acute AMR, but acceptable medium-term graft survival. So transplant, of course, would be possible, but again, it would require adaptation of follow-up and maintenance immunosuppression. And finally, we also have a certain group of, an important group actually, of patients which would be those with potential cellular memory, with all the serological tests negative at the day of transplantation, but that perhaps they put us in trouble in terms of deciding whether this patient might have a recall secondary immune response and therefore be at risk, a high risk of AMR. So these are those with historical DSA, particularly class 2, that have not clearly disappeared, patients with multiple pregnancies, previous transplant, repeated mismatches, and those with transfusions and high CPRA but without DSA. We believe this is a different category, but not similar to those that would be called or so-called as naive patients without cellular memory and no serological memory. So this is a summary of my talk, and we have here 2 questions for the audience. I don't know, Nizam, if we can read them. We have time for that.
Yeah.
Okay, so the first question is related to the situation at the time of transplantation, whether we pay attention on the presence of donor-specific humoral cellular memory in absence of serological evidence of DSA at the time of transplantation. So there are no true correct answer. We believe there might be different approaches, and we would be interested to understand the approaches that every one of you might consider. So the first one would be, we don't generally take into account when it comes to patient selection, decision-making. We do take into account, but we don't change our therapeutic approach. We do take into account, but we adapt our immunosuppression therapy by increasing either or both the induction and maintenance immunosuppression and patient follow-up. And finally, we considered it as a contraindication to transplantation.
Okay, so that should be appearing on your screen now as a poll. So please do vote. We'll just give a minute for that to go through. In fact, people are voting on the second question, I think, already. Or also, maybe, do you want to speak to that?
Forward. Yeah.
Yeah.
So the second question would be related on the assays dealing with the serological memory. Again, at day 0, at the time of transplantation, and we're dealing with a deceased donor kidney transplant patient. And the first sentence would be, we just need negative CDC cross-match in an actual serum, regardless any other result of another immune assay to move forward kidney transplantation. We always need a negative CDC cross-match or flow cytometric cross-match, regardless the presence of a current DSA in a single antigen bit assay. In presence of a CDC cross-match or flow cytometric cross-match with a DSA with an MFI lower than 5,000, we may accept undergoing kidney transplantation. And finally, a proposed sentence would be that we need a negative CDC cross-match or flow cytometric cross-match as well as a negative DSA to move forward for deceased donor kidney transplantation.
Okay, so people are still voting. Please do carry on voting. Maybe what I'll do is I'll come back to those questions and ask you to comment on them, Oriel, in terms of what people have said. There's one question on the Q&A from Yakov Goikman, who asks an interesting question that I think we probably all struggle with. What's your opinion about the clinical significance of HLA-DP DSA antibodies? And do you think we need to remove them?
That's another cornerstone, right? Difficult question. First of all, We unfortunately we don't always have the DP HLA typing of our deceased donor, at least. So this is a main issue if we want to decide whether to move forward in a deceased donor transplant. I think it has to take into account the whole repertoire of these patients, unless we do have the HLA type of the respective donor. So I would be cautious, but again, unless we do not have the HLA type of the donor, it might be difficult to take a decision in this regard.
Okay, thank you. And do you want to maybe just, I think we're just coming to the end of our time for this section. Do you want to comment on the results of the two questions, the polls? Can you see those on your screen, all right?
Yeah, I think the first one, I think it is very interesting. I think most of the people do take into account and try to adapt immunosuppression according to eventual cellular memory. I think it is something that we are all also struggle with that, since we don't have really any immunoassay today in our clinical practice to use it. But what it reflects probably is that we do have experience with somehow complication with this type of patients, regardless their serological memory. So I think it is very illustrative, this answer. And regarding the second one, I think there was a number of potential, correct answer, not correct, but approaches. And I think the third one, it's also pretty illustrative to see how important is try to transplant sensitized patients at low risk, at least with this CDC cross-match and flow cytometry cross-match, despite that they still show this low-level DSA. So I think it illustrates very well the problematic issue that we're all facing. Okay,
great. Thank you very much indeed, Aurel, and thanks to everyone for voting there. I think they're really interesting findings. So we'll move on to Christophe Legendre from the Necker Institute in Paris. He needs no introduction, really. I'm sure you've all heard of him. He's going to talk about how we risk stratify patients and what desensitization strategies are available. Christophe, thank you. Still on mute. I think you're off mute now. Yeah.
Okay, next one. Next one, please. Okay, this is our experience at Necker, and you see that these are the patients that are listed, and you see that 24% of our patients are highly immunized, and overall 60% of our patients are listed with anti-HLA antibodies. And you see that the consequence is, for example, for these highly immunized patients, the waiting time is 6.2 years compared to 3 years when they have less antibody. So obviously it's a very big problem. Next one. And what is puzzling is that when you transplant patients with DSA and you look at these patients at 3 months, you see that some of these patients, these are the red square, will develop chronic antibody-mediated rejection, while the same patient with the same level of DSA will not develop chronic antibody-mediated rejection. So obviously, there are different categories of antibodies. Next one. And here you have the same representation that Aurel talked about. You have the risk of antibody-mediated rejection going up, and then you have the level of antibodies with, at the beginning, only a low MFI, and then the cross-match, flow cross-match is becoming positive, and then the CDC cross-match becomes positive. But we don't know exactly. There is not a straight correlation between the level of DSA and the risk of antibody-mediated rejection. Next one. That said, there is still a correlation. And if you look at this data coming from Paris, you see here in red and in blue the patients with more than 3,000 MFI at time of transplantation. Next one. And if you look a little here, you see that the patients with less DSA have better results. And the 3,000 threshold has been found also by our colleagues from Germany. Next one, and you see that when you have an MFI less than 3,000, it's better than when you have MFI greater than 3,000, but still there is a price to pay. And especially for living donors, the results are not as good as in patients without monoclonal antibodies. Next one. All these antibodies are not the same. And for example, when you have DSA fixing C1q, you see that the results are a lot less worse compared to the patients without C1q. And when you look at next one, this meta-analysis, it looks at all the categories of DSA, fixing C1q, fixing IgG of the IgG3, fixing C3d or C4d, and you say that overall, when there is an interaction between the complement and DSA, the results are worse. Next one. So how is it possible to transplant this patient? There are three ways to do it. The first one is to do nothing, to wait for non-incompatible donors. It sometimes works, but you have to wait for months or years, and we know that this type of dialysis is bad for the results of transplantation. The second option, next one, is to have acceptable mismatch program or kidney pairs exchange program, and I won't speak about it because the next speaker will explain in detail what it is. It works, but not for all patients. And finally, the third way, next slide, to use, to live with this DSA is to desensitize the patients. And this desensitization may occur before transplantation or immediately before transplantation, like in Vienna, or you can desensitize also post-transplantation like we do in Necker. But in all cases, the CDC has to be or must be negative. Next one. The most current used desensitization method is this one, coming from Stanley Jordan unit. He combined IVIG and anti-CD20 before transplantation, and you see that it decreases the CPRA. The other option, next one, is to use plasma exchange with low levels of IgIG at the end of the plasma exchange in order to minimize the rebound. But we have also other drugs like bortezomib, tocilizumab, and what is interesting is none of them are approved by FDA. So far, we don't have a single drug whose indication is the patients with a high level of DSAs. Next one. What are the results of desensitization? In the United States, it's better to be desensitized than to be transplanted with the current rules or to stay in dialysis. So a better result as long as you can transplant the patient. The next one, this shows that the results are worse and worse as long as you have only DSA without a positive flow cross-match. And then when the cross-match, the flow cross-match is positive, it gives worse results. And finally, on top, you see patients with a positive CDC cross-match that we have a very high level of acute rejection. So it's better than nothing, but it conveys a risk of acute mediated rejection. Next one. Interestingly, the English, the UK experience shows that when you do this kind of desensitization, you do neither better nor worse, but you transplant all patients that wouldn't have been transplanted otherwise. So this is still a positive result. Next one. These are the molecules that are currently studied or that are going to be currently studied. Of course, you cannot see on this slide, but this is an excellent review from Stanley Jordan. And we have several drugs like drugs directed against B cells, more potent than rituximab. We have drugs that are devoted to B cells, but like the bortezomib or the calfilzomib. you have drugs that are inhibitors of proteasome inhibitors, and so far, none of these drugs have given very nice results, very positive results. So probably the most interesting drug we have now, next slide, is this bacterial Ig degrading enzyme, IDES or imlifidase, because this drug cleaves the IgG, and you see that after a few minutes or hours, in the blood of the patients, there is no IgG intact. The IgG has been cleaved, and this stays for a small week, 3 to 7 days. And this new drug has the indication of transplanting patients with very high level of DSA, and it negativates the cross-match, be either the CDC or the flow cross-match. So this is something quite new. Not that many patients have been tried, but this is a very promising drug, and this is probably the first one to be devoted to this kind of patients. So things are moving in this area, and probably very soon we will be able to combine several of these drugs in order to transplant these more and more frequent patients. Thank you.
Christophe, thank you very much indeed. That was fantastic, as usual. We haven't got any new questions come up yet, so if people do have questions, please type them into the Q&A. And while people are thinking about that, because we've got a couple of minutes, I'll maybe ask a question. So certainly, I don't know about France, but certainly in the UK, we've seen over the last few years, people shift away from direct antibody incompatible transplantation, and they've tended to avoid desensitization, in part because of kidney sharing scheme, but also because of the perception that this is a high-risk transplant with significant complications. What's your view about that? What's happening in France at the moment? Are people moving away from it? And do you think it still has a significant place in the approach to patients who have sensitization?
It's interesting to compare France and UK, because I think that's we're doing about the opposite. We have an acceptable mismatch program that works very well. So we're transplanted in our group about 30 patients a year with this kind of acceptable mismatch program. But we don't have a kidney paired exchange program that works. Our program doesn't work. So most of the teams are very reluctant to transplant patients with DSA. But more and more teams are using this attitude, but everyone agrees that it's high-risk patients. The incidence of infections is higher. Maybe in the future we'll see that other two-role complications will be more present. So I would say that about 20% of the French teams are doing this kind of transplant, but the majority is more conservative and use transplantation without DSA, which gives, of course, better results.
Okay, thank you. We've got a question from Raj Thirasingham in London. And he says, Christophe, do you believe that the C1q binding is a surrogate for high MFIs, as some authors have suggested?
It's not the only one. It's probably the one that has been the best proven, because it has been proven over a very high number of patients. But probably if you compare, IgG3 is probably better than C1q. And like I showed in this meta-analysis, as long as your DSA are able to activate complement, these antibodies have probably the same strengths and the same power, but C1q is not the best in spite of the fact that we published this paper. It's probably IgG3 even in our hand that is better.
Yeah, I would agree. Our experience of C1q when we've looked at it has been that it hasn't helped us to predict poor outcomes, albeit in a relatively small number. Oriol, do you have any comments about the situation in Spain and how people are approaching these patients in Spain?
Yes, so the sensitization is not a very common approach yet, although there are some centers that they conduct desensitization, particularly in living donation. But I would say that former programs would be less than probably 15% in our country. I think we have realized that, as I showed before, that these numbers have significantly increased, and perhaps we should actually focus on trying to understand that the outcomes are never going to be the same as an HLA compatible, but for them, as compared to remaining on dialysis, would be better. So I think we're not doing a lot, but probably will increase in the next few years.
Okay, thank you. So I think what we'll do now is we'll move on to Sian Griffin from the University Hospital Wales, and Sian's going to talk about the outcomes after HLA incompatible transplantation and the place of kidney sharing schemes. Sian, thank you.
And thank you very much to the two previous speakers for providing the background to the outcomes that we focus on. I have the following conflicts of interest to declare from advisory board commitments. And I'd like to acknowledge Matthew Robb, who's a senior statistician at Organ Donation and Transplantation, for his input on the results of our kidney sharing scheme. We naturally focus very much on graft and recipient survival following transplantation. And I think, as Christoph and Oriel have just alluded, we tend to compare our outcomes to the ideal non-sensitized, non-incompatible transplant, whereas in fact the more appropriate comparator group for some of these patients may be remaining on long-term dialysis, which is their realistic alternative. I think it's important to be aware that we're becoming much more sophisticated on our assessment of outcomes, and these becoming much more patient relevant. And this has been led by the Standardised Outcome in Nephrology, or SONG initiative, led by Alison Tong in Sydney. And this group have worked over the last few years to develop a consensus for patient-relevant, patient-focused outcomes in all aspects of nephrology, with one theme of their work being outcomes following transplantation. And I think it's very interesting to see the direction of travel beyond the headline results of graft and recipient survival to look much more on the outcomes that matter to patients, including life participation. So I think we are going to be much more sophisticated about assessing outcomes in the future. We've seen these slides already and are very familiar with the inferior survival of HLA incompatible transplantation compared to those who have a compatible donor, with data from the USA and the UK in living transplantation, and then the data from NECA in deceased donor transplantation, showing inferior graft survival for patients who undergo transplantation after antibody removal. However, I think it's also important to note that the 5-year survivals in these groups are still pretty good. So even with a cytotoxic cross-match prior to transplantation in the US, 60% of the grafts are still functioning after 5 years. So these aren't terrible outcomes. They're not as good as they could be, but they're not beyond the realms of what we perhaps should be offering our patients. And we've also heard from Christoph about risk stratification, considering complement fixation and the level of donor-specific antibodies and the subsequent risk of transplant loss. However, it may be more important to consider recipient survival, and the data from the US shows a clear advantage for undergoing desensitization to receive a transplant compared to remaining on dialysis or continuing with dialysis and receiving a compatible transplant at a later date. And although the data from the UK is not as stark, there's clearly not an inferior recipient survival following desensitization. And I think it's also important to note that in both these studies, there was very careful matching for a number of factors between all the groups who were studied. So in terms of initiatives to facilitate transplantation for sensitized recipients, and we've heard a little bit about this already in terms of how we approach deceased donor transplantation and the use of sharing schemes. The offering system for deceased donors in the UK has recently changed, because as you'll see from the caterpillar graph on the right, we appreciated that with increasing sensitisation at the time of joining the list, the chance of waiting a long time for a transplant was very much increased, particularly approaching a sensitisation of 100%. So we initially gave an absolute priority for long waiters, those who've waited more than 7 years for a transplant. And in the new offering scheme, offer prioritisation for those with a CRF of 100% or a matchability score of 10. And we've heard how the approach of Eurotransplant with the acceptable mismatch scheme has also enabled significant numbers of highly sensitised patients to receive a compatible transplant. The kidney sharing scheme in the UK, I will describe in the next few slides, but I think it's also important to actively manage the waiting list, to consider delisting of low-level antibodies, which is associated with a favourable outcome following transplantation. And this can either be done in conjunction with deceased donor transplantation or with the kidney sharing schemes. This figure shows the impact of the new offering scheme on the transplantation rates in highly sensitised patients in the UK. So on the left are the patients who were transplanted under the previous offering scheme, and then on the right, those transplanted during the first 6 months of the new offering scheme. And there was an increase in the number of highly sensitised patients, difficult to match patients, patients from the Black, Asian minority ethnic community, and those who'd waited a long time for their transplants. A lot of statistical modelling was done before the initiation of the offering scheme, but it's really nice to see that playing out in real life. The National Living Kidney Sharing Scheme in the UK was initiated in 2007, initially with just two-way paired exchange, but that rapidly expanded to three-way pooled exchange. And we then initially encouraged our altruistic donors to start short donor chains. That's now increased to long donor chains. And our expectation of all our altruistic donors is that they will donate into the Living Sharing Scheme. The generation of a chain leads to a kidney at the end, which can then be donated to the waiting list, so that patients who do not have a living donor are not disadvantaged by being excluded for consideration for an altruistic donor. And this graph shows the number of patients in our quarterly matching runs, beginning with the 9 patients in April 2007 to the most recent matching run, including 277 patients, which is the norm for the quarterly matching runs now. You'll also note in the orange bars are the new patients joining the scheme, and the blue are the existing patients. And inevitably, the pool of existing patients is an accumulation of those who are very highly sensitised, for whom it's difficult to identify a compatible donor. Since 2007, nearly 2,500 patients have registered in the kidney sharing scheme, median age of 47. Interestingly, although more are female than male, there isn't the marked excess of women that you might expect given the increased risk of sensitisation following pregnancy. And then considering sensitisation, nearly 40% of patients registered are highly sensitised with a CRF above 85%. So who has received a transplant? 43% of those registered in the scheme have received a transplant, and that includes 132 patients who had a CRF greater than 95% at registration. And this is a great achievement, and those patients have a compatible transplant. Unfortunately, the other side of that is 565 highly sensitised patients registered in the scheme have not received a transplant. And I think I'd like to refer back to the previous speakers and say we need to find a balance between an ideal compatible transplant and accepting a less good outcome, but a preferable outcome to dialysis. And so to summarise my thoughts about this, I think both graft and recipient survival need to be taken in the context of what the alternatives are for those patients. I think there's an urgent need to broaden the inclusion of patient relevant outcomes in our studies, and the SONG initiative is leading the way on this. I think for patients who undergo an incompatible transplant and are exposed to increased intensity of immunosuppression, it's important for the consequences of that to be considered as part of the outcomes post-transplantation. I think we're getting better at risk stratification, but I think there are a number of what have largely remained research assays for improving risk stratification that have not made their way into clinical practice. And I think the combination of that, together with more sophisticated consideration of outcomes, will allow us to communicate much more accurately with our patients what they can expect from a transplantation that is appropriate for them. So thank you very much.
Thank you, Sian. That was great, and I think you're spot on with the point that you make that that although incompatible transplants have their risks and may have a poorer outcome compared with a compatible transplant, for many patients, a compatible transplant is not on offer. So the comparison really should be for many patients should be for an incompatible transplant versus dialysis. So can I encourage people to type in questions? Now, I think I'm right in saying that you probably can't see other people's questions. So you may think that you're the first person typing in, but you're not. So please do type in some questions. We've got a few minutes. You can direct those to Sian, or you could direct those to either of the other two speakers as well. Sian, can I ask you, you mentioned delisting. I think probably some of the audience won't be familiar with what we mean by that. Could you go into that in a bit more detail?
Yes, I think the results from the single antigen bead analysis of MFI of donor-specific antibodies or HLA-specific antibodies are not binary. And as Christoph nicely showed, we can stratify the risk of AMR and graft loss associated with antibodies depending on their MFI. So there may be patients on the list who over time the MFI of their antibodies may fall. And so they may initially be listed as an unacceptable antigen, but should the MFI fall to an acceptable level, or the transplanting team decides that for that individual patient, it might be appropriate to consider a relatively low risk incompatible transplant, then that specificity can be removed and a transplant allowed that has that antigen.
Yeah, thank you. And I think that's obviously the allocation systems vary across different countries, but in many places, a kidney will never be offered if there is antibody to some of those HLA types, even though the cross-match might be negative. Okay, so we have an anonymous question. To Sian, do you believe we have a good enough predictors of outcome for both HLA incompatible and for dialysis itself to advise patients on which option provides better outcomes?
I think we have fairly high level crude guidance as to how to advise patients, but I think we could get much better at it. In addition to the characteristics of the antibodies themselves, Oriel showed a slide of the other factors that can influence the response to antibody, including perhaps complement genotypes on the endothelial cells. And we're aware that the cytokine milieu and levels of B-cell survival factors can also affect the response of the antibodies post-transplantation. So I think there's a lot we could do to quantify the risk for a patient. I think we are probably better at estimating their risk, their chance of survival on dialysis. And so in the UK, and I think other countries, there's a lot of detailed collection through registries of survival by different characteristics on dialysis. So I think we can give survival figures for both, but we could be better at it. And I think we need to move beyond survival as well to other factors that matter to patients, which I think will be addressed as part of the SONG initiative.
Yeah, absolutely. Very often the patients are not too fussed about a difference of 5 or 10% in graft survival. It's really quality of life that they're interested in. One thing that we've certainly seen, and Christoph and Auriel may want to join in here, is we've seen a phenotype of early aggressive antibody-mediated rejection, which can often result in graft loss. We tend to use complement inhibitors quite aggressively at that point. But what we've also seen is, in the first couple of weeks, a memory response with a big rise in antibodies, often into the tens of thousands, and yet no graft dysfunction at all. And in that situation, what we do is sit tight and watch. We might do a biopsy, but if the creatinine is okay, we won't intervene. So one of the things that strikes me is if we knew before we started that antibody wasn't going to cause a problem, we probably wouldn't have bothered trying to remove it. So do you have experience of that? And do you want to comment, either yourself, Sian, or Christoph or Auriel, on how we might approach working out which donor-specific antibodies are going to cause a problem? And I think this goes beyond C1q and IgG3.
We have seen cases to that. I recall one patient with DQ antibodies and a negative cross-match going into transplant, and so both cytotoxic and flow cross-match. So she had pre-existing antibodies which persisted post-transplant without graft dysfunction. And similarly, I recall another young patient who had low level antibodies going into the transplant. We didn't think it was particularly high risk. And she had a very rapid rise, severe rejection. She lost her graft about 1 year later. So certainly for her, I would have wanted would have wanted more information that would have predicted a poor outcome. So I don't think we're there yet. And also looking at the survival curves of the patients in the UK at sort of 5 years, you have 75% survival. I'd like to know what the difference was between the group that did well and the group that didn't do well. So I think we're missing parts of the puzzle.
Yeah, absolutely agree. We've got a question from Fernando Moss. It's not strictly on this topic, but it's related to it. And Fernando says, what's your opinion about ABO incompatible transplants if the sharing scheme is not giving a solution to those pairs?
So in the UK, I think most units would offer a number of runs in the sharing scheme to see if a compatible match can be identified. But if not, several units offer ABO incompatible transplants, except for those patients who have particularly high level antibodies. And ABO transplantation is a scenario when we have seen a rise in antibodies subsequently without graft dysfunction. So they do behave very differently.
Yeah, absolutely. And I mean, I think the data both for ABO and HLAi transplants shows that if you're going to get a match in the kidney sharing scheme, that's likely to happen after about 5 or 6 iterations. So each iteration happening every 3 months. And therefore, the incremental chance of getting a match, if you've not had a match after about 1.5 years, is very small. So we will tend to put patients in for that period, but then take them out and offer them a direct transplant if they haven't had a match. The other important thing I think to mention is that for blood group incompatible transplants, there's a big difference according to which blood groups are involved in terms of how likely you are to get a match in the sharing scheme. And that's an important consideration. So B into A, I think the latest figures are about a 40–45% chance of getting a match.
Yeah, Nizam, if I can comment on that also.
Yeah, please go ahead.
I think it is a very interesting question indeed. So it depends very much, for example, on the, as you said very well, the titers of the ABO, but at the same time, you have a very good HLA compatibility with this donor. Perhaps since the biological setting is completely different, and we know that we can really do very well with current desensitization therapy for ABO, I think it's worthwhile perhaps to go forward and get the advantage of a good HLA compatibility despite the ABO incompatibility. So I think it has to be a balance between both compatibilities in terms of ABO and HLA to decide that.
Okay, yeah, I absolutely agree with you. Okay, we've got one last question, which I'll ask Sian to answer. Anonymous, again, I don't know if it's Christoph typing these in, but but the question is the iBox, a risk prediction score, many of you will be aware of, coming out of Paris, combining functional, histological, immunological allograft parameters together with HLA antibody profiling showed good performance in predicting the risk of long-term kidney allograft failure. Is this a tool which may be adopted in the UK?
Yes, I think it may well be. I think Christoph did type that question. No, I think the iBox is really exciting. And I think having that sort of means of having a surrogate outcome for transplant and particularly for trials is going to be really important, particularly as 1 and 5 year survival rates are generally so good. So I think it's a really exciting development alongside with the other considerations of patient-focused outcomes. Thank you for the question.
All right, thank you. Thanks, Sian. So I think it's probably time now to just start wrapping up. I'd like to thank all the speakers for great talks, all of you for joining in, and Hansa again for supporting this. Can I re-emphasize that what this was about today was not to tell you everything about antibody incompatible transplantation and HLA antibodies, but really as the first step in trying to move towards putting together a guideline which hopefully will be useful. So please do tell us what you think we should be covering, what you think we might have missed, what things are important to you. And you will be able to reply either on the website or to reply to emails that will be sent out. I'd like to thank Giovanna as well, in particular, Giovanna Rossi, who's been fantastic at organising all of this. So you will hear from us again, and please do feedback to us. Thank you very much indeed for joining in. Thank you.